Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health answering your questions about quality programs and the transition to value-based care. My name is Hadley Taylor, a MIPS quality program consultant, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hello, Dr. Mingle.
Good morning, Hadley, and good day to all of you tuning in. It's great to see you again. I am Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
Before we get started, I want to remind all that you can always send us your questions for Dr. Mingle on LinkedIn, YouTube, or by email at hello@minglehealth.com. Let's get started. This week, Dr. Mingle, our questions are coming from my clients, really, and my colleagues' clients about value-based care and increasing the value in our healthcare system. Some of questions that my clients are asking are, do we really have a problem with value in the U.S. healthcare system?
Great question, Hadley. The answer is yes. We've got a big problem. It's not always visible from the ground. I've nearly been in fistfights with people who are adamant in their insistence that we have the greatest healthcare system in the world. This view is held by smart and observant people who have my respect. They've challenged me to understand the dichotomy, but you can't ignore the evidence right in front of us. High error rates as exposed in the book To Err is Human, written by L.T. Cohn and published in 2000, or data from the Organization for Economic Cooperation and Development, the OEDC, that shows per capita cost of healthcare in the United States is well above the cost in any other country. And in multiple different measures of the effectiveness of healthcare, the U.S. ranks low against the other members of the Organization for Economic Cooperation and Development, that's the OEDC. High cost and low effectiveness equals low value. We have a problem. Data from the Dartmouth Atlas, through which Dr. Jack Wenberg and his associates have been publishing data on unwarranted variations in healthcare experienced in different U.S. communities. There are vast differences in cost and quality of care in our communities, unexplained by differences in demographics, culture, incidence of disease, or other key measures. In the U.S., we produce a steady stream of advances in sciences of diagnosis and of treatment, but we neglect the science of healthcare distribution. We're very good at distributing profitable healthcare, but we frequently fail to deliver cost-effective care. So yes, great healthcare is available and often accessed in the U.S., but it is poorly distributed and lacks systemic discipline and error controls that exist in many other U.S. industries.
So then, is the attention that we are paying to quality reporting actually doing anything to improve healthcare?
Great question, Hadley. I've not yet seen any great evidence that it's making a difference. But that's not to say that we should stop. It seems obvious that you can't increase the value of healthcare with strict management limited to the management of the healthcare dollar. Efforts to do that have been going on for decades without much effect. Healthcare improvement efforts that cut dollars without addressing quality incentivize neglect of complicated and expensive patients. We have to manage or incentivize both low-cost and high-quality care together. I'd say that measurement of quality is necessary but insufficient to build value into healthcare. And when quality measurement infrastructure is anchored on a regulatory program, like the Merit-Based Incentive Payment System, that's MIPS, it's particularly prone to gaming. I fear that as long as our attention to quality measurement begins and ends with the scope of the regulatory requirements, the true value creation in healthcare will tend to elude us.
Great answer. Thank you. So then, next question from me, Dr. Mingle, is I've heard you talk about systematizing value before. Can you explain that? Can you clarify that a little bit for me?
Great question, Hadley. Paul Batalden of the Institute of Healthcare Improvement and the Dartmouth Institute riffed on a quotation from Arthur Jones when Paul said, "Every system is perfectly designed to get the results that it gets." To get more value out of our system, we're going to have to change our system. And what is the system? The healthcare system is the sum of its parts. The system includes, but is not limited to, what healthcare data is collected, who is it collected from, who collects it, how is it collected, where and how is it stored, how is it accessed, and how do we recognize healthcare needs of both the met and the unmet varieties. If we want to do a better job, if we want to eliminate errors of omission and errors of commission, that is, doing everything that should be done and avoiding anything that should not be done, we need to build and refine a system that assures great performance. There are three essential parts to that system. It's the people, the process, and the technology. Your system is the people, processes, and technology that delivers the product and services you want to deliver. People are capable, trained, monitored, and motivated to deliver great care. Process is documented, followed, regularly updated to correct observed deficits and to keep up with new medical evidence. And technology optimize the use of available technology to enable your people to efficiently and effectively deliver your desired processes.
Okay, so given all that, then, what are your suggestions for us to build a quality management system that does increase value in healthcare?
The measurement system can't be merely reactive to the regulatory requirements. It can't just begin and end with the requirements, whether they're the merit-based incentive payment system, that's MIPS requirements, the APM performance pathway, that's the APP requirements, the healthcare effectiveness data and information set, that's HEDIS, or any other federal, state, or insurer-sourced requirements. I define system in the last question as the people, processes, and technology that deliver on your intentions. Your people have to be involved. There needs to be a shared understanding of what you intend to deliver to your patients. What are the essential elements of that product, service, or set of products and services? What risks or errors does your system need to address? It's essential that everyone on the team knows where those policies are kept, has a hand in creating them and updating them when they need to be updated. Now, processes need to be documented. Think policies and procedures. It should be written. Should not only be accessible, but also routinely accessed. The moment we start relying on memory to keep us on track is when errors start to happen. It needs to be dynamic. When there is awareness of novel errors, that's new errors to our system, it should be updated to prevent recurrence. When there's new evidence, it must be updated to deliver the new intentions. Despite the existence of written protocols, your practice should not be in service to the protocols, but the protocols must be in service to your practice. Depart from the protocols when you need to and update the protocols to address that same need in the future. Optimize your current use of technology. There are three parts to your foundation of technology. One, a patient portal. Get input from your patients, give output to your patients, and provide secure and reliable communication. Don't just think in terms of a web-based portal, but as a help desk that provides access for your patients how they want it and when they want it. It might include phone access, text messaging, secure messaging, whatever they want and whatever they feel comfortable getting answers from you about their health. It includes an electronic health record to hold data about your patients and your encounters with them, to efficiently and effectively access data about your patients, and to correct misinformation and track changes in your understanding and diagnoses relative to that patient and treatment plans over time. You want fast and effective data entry as close to the data as possible. And when I say as close to the data, that means collect your patient's words whenever possible. And whoever in your practice collects the data, have them document that at the time rather than passing that on to the doctor. You want fast and effective data access, standardized structured language and location for every important element of the data. But when you're documenting, you want to keep that brief and clear. You should not document anything that's already in the chart. That excess documentation then tends to weigh down the chart and be ultimately a barrier to data access. You need a measurement system to identify met and unmet healthcare needs in your patients. There are not, as common measurement regulatory systems tend to imply, 6 measures that define the quality of your care. Medical evidence suggests tens of thousands of individual interventions, each represented by a potential measure needed by our patient population. Your system should be able to measure the subset of those evidence based interventions that are applicable to your practice. There is a vital interaction between your EHR and your measurement system. Your EHR must hold your best current understanding of the data elements that sort your patients into denominators, of the data elements that show the met status of your patients on any intervention you intend to provide, and of the exceptions or exclusions that apply. Your measurement system must reflect your best current understanding of the desired relationship between the denominator elements, numerator elements, and exception elements. So a lot of work to be done, and it's not going to be completed if we just limit our vision to the regulatory requirements.
That is a really great answer, Dr. Mingle, and I really appreciate that. And I'm sure our listeners do too. Speaking of buy in across the practice and how to start going back a little bit to basics while still managing to make it all work for our patients and for our practice. That's amazing. Thank you.
Thank you for the great questions, Hadley. I look forward to our next session.